I would request every patient not to skip any medication, especially tacrolimus, everolimus, Cellcept or steroid, whichever has been prescribed to them. These are the 4 pillars of immunosuppression. New graft which is given to the patient can fail due to we give, as a doctors and team, we give certain medicines which modulate or suppress our immunity so that our immunity is not able to reject the liver. A fight between immunosuppressive medicines and our immune system to balance out so that the graft, the liver, new liver, remains well.
So rejection happens only with incompliance of the medicine.
TCMR or ACR is treatable in more than 90% of patients. If you have any intercurrent illness like diarrhea, fever, or stresses of life, physical or mental, then levels can vary. Grapefruit diet, when taken with tacrolimus, can increase the level of tacrolimus multifold and cause side effects of tacrolimus like tremors, kidney failure, mental cloudiness. All these things can happen. So grapefruit from our side is no. So please do not alter the doses by yourself. Liver transplant, a new organ, is very precious to you. Just because somebody says that I am taking lesser dose, please don't listen to that person.
Dr. Vivek, thank you again
Pleasure.
for agreeing.
Pleasure,
to be with
Hulka Roy.
us.
Thank you very much for this podcast. It's very important, informative session for all our patients because they should know how to take care of their, as well as their liver's health, new liver's health, to the maximum so that they can live much longer.
Thank you. So rejection and graft failure are different things, right?
Oh yes.
What is the difference? Because when I look at the symptoms and all, I cannot differentiate it.
Okay. So let's talk about what is graft failure. Okay. The new graft which is given to the patient can fail due to various reasons. This failure can happen very early also or very late also, right? This is graft failure. Graft failure, one of the reasons of graft failure is rejection. So there can be other reasons also, like biliary complications or trauma or new diseases. So there are many reasons why the graft can fail. But rejection is the most feared complication with which graft fails. Is the most common complication. So graft failure is the final effect. Why it happens is because of rejection. So rejection is the reason. Graft failure is the final effect. The final effect can happen because of rejection or many other reasons. So this is the difference.
How does rejection happen?
Rejection, see, you should know that our body is very complex, number one. Whenever a foreign material or foreign body enters into our body, our immune system tries to reject that and push that out of our body, right? So this is a basic thing about rejection. We give, as a doctors and team, we give certain medicines which are called as immunosuppressive immunomodulatory and suppressive medicines, which modulate or suppress our immunity so that our immunity is not able to reject the liver. So there is a critical balance going on in the body, a fight between immunosuppressive medicines and our immune system to balance out so that the graft, the liver, new liver, remains well for a long term, right? So our rejection main reason is our immunity tries to kill the new liver, but our medicines will protect that new liver. So we have to maintain a critical balance between medicines and our immunity, right? So this is how rejection happens. Now there are various aspects of immunity. Rejection can happen because of various reasons. It can happen because of antibodies in the body, or it can happen because of T cells or B cells. B cells is mainly related to antibodies. T cell is basically TCMR, which is related to the cell rejecting the liver. So let's not go into too much into internal mechanisms why it happens, but all these antibodies and cells will try to kill your liver, but our medicines will try to protect. They will create a protective layer around the liver so that liver can live a longer life. This is in simple terms what is rejection is.
So rejection happens only with in compliance of the medicine, right? That's
No, that is not right. There are if the patient doesn't take medicines or not compliant, then the chances of rejections are much higher, right? Because as I told you, basic thing that our medicines create a protective layer around the liver. No patient after transplant should skip the medicines. If they skip even a single dose, right, we will have to see how to introduce that dose again into the body. If it is less than 12 hours, they can keep on taking, same dose. They can, if they have skipped in the night dose, suppose, and they remember in the midnight, they should take that dose, right? If it is more than 12 hours, then they should double up the morning dose. So there are many ways we can introduce the same dose again in the body.
We can double up the level.
No, it will not double up the level. We have missed one dose. We have now added one more dose. That's just one more dose. Rest treatment plan remains same. So immunosuppressive medications are the axis and key to your graft survival as your own survival. So I would request every patient not to skip any medication, especially tacrolimus, everolimus, Cellcept or steroid, whichever has been prescribed to them. These are the 4 pillars of immunosuppression. Please don't skip them. Please don't try and undervalue them. This is very, very important.
We used to have no patients with rejection earlier. As I am in this field for the last 10 years, we did not have rejection problems. But lately, patients started to listen to their neighbors, to their friends, or to, like, when they come to transplant together, someone is taking 0.5, they're taking 2 milligrams, and then they just reduce dose by themselves.
Yeah. So I think
Is reducing dose has the same effect, or?
Ulka, you have hit the nail. So these days, when we give immunosuppressive medication, they are not one envelope for everybody. They are tailored to the needs of patients. Every patient is different. Every liver is different. There are many patients and many livers who metabolize these medications very less and they maintain the levels very well. But there are many patients who metabolize them very fast. So we have to give higher dose to them. So it's very important to understand final effect has to be the level, not the dose. Some patients can have the same graft function at 0.5, but other patients might require 3 milligrams also. So please, please, please do not alter the doses by yourself. Liver transplant, a new organ, is very precious to you. Just because somebody says that I am taking lesser dose, please don't listen to that person. Talk to your team. Team is always available. And if you are not able to talk to your team, then at least maintain the levels which have been prescribed to you. We need to maintain certain levels of tacrolimus, everolimus in the body. And those levels will determine your graft function as well as your long-term survival.
And how do you differentiate rejection from biliary problems?
So there are 3 things. One is rejection, second is infections, and third is biliary complications. All of these 3 problems usually have the liver function tests deranged. So it's very perplexing for patient that what is I'm having. Am I having a rejection or some kind of infection or a biliary complication? So it's very difficult for patients to understand. In fact, many surgical teams also, they do multidisciplinary meetings to reach up to a diagnosis that what primarily it is, because the treatment strategies for all three are very, very different. Right? Now let's talk about rejection first. Usually what happens in rejections are various kinds, but we talk about the most common kind of rejection, which is called as the TCMR. Okay, which is T cell mediated rejection. It is also called as the acute cellular rejection. Okay, in because if you see, it is acute, it is cellular, and it is rejection. The liver cells are damaged in this. When the liver cells are damaged, there are two enzymes which are released from the liver: SGOT, that is AST, and SGPT, that is ALT. Their levels rise in the body. They can rise 2 times, 3 times, 4 times, and in many severe rejections, they can rise many folds, 10 times, 20 times also. Normal levels are less than 30 to 40. Now, having said that, this is a classical acute cellular rejection where enzyme levels go up. Later on, bilirubin goes up. Later on, other enzymes like alkaline phosphatase, gamma GT goes up, and after that, bilirubin goes up. This is how a rejection episode presents to you. So, when your enzyme levels are high, you should suspect a rejection. Contrary, if there is a biliary complication, usually itching, alkaline phosphatase, and gamma GT, they rise first because it's a bile duct problem. And bilirubin also rises. SGOT and SGPT, AST and LT rise later. But there are many mixed patterns also which we need to understand. Okay, because biliary complications are not detected as soon as they happen. They take time. By the time they are detected, AST, LT also might rise. Okay, so it's a complex problem. You should consult your doctor and team to reach up to a final diagnosis. But the take home message is whenever the enzymes rise or bilirubin rise, you should suspect either of these and consult your doctor.
And mainly biopsies are told, right? So if is it possible like to get the biopsy in Uzbekistan and get it treated in Uzbekistan?
See, getting biopsy should not be a problem, but reading biopsy is a problem. It requires great lot of expertise to diagnose what is there in the biopsy. In biopsy, rejection, infection, biliary complications, recurrence of various diseases, pathologists should be well trained for all these problems. I think we have set up some mechanism that biopsy can be done there and can be read here. But there are certain situations which are emergency situations, like very severe acute cellular rejection. If that happens, then we can't wait for biopsy. So obviously, biopsy is very central to treating rejections. It has to be done because if we start giving steroids to every patient, that is not advisable. It can be detrimental also. Just giving you an example, suppose a patient has rejection and another patient has a recurrence of disease, maybe hepatitis B virus, A virus, or any other viral infection which rises the enzymes. Now, in both the patients, enzymes are more. If you treat the both of them with the steroids, the infection patient will lose their graft because infections will increase, but this patient will get cured. So every enzyme rise is not an rejection. So all the enzyme rises should not be treated with the steroid pulse. So that's why biopsy and proper reading of that biopsy is important.
Thank you. And we have some patients who think that if they eat well, their immunity will get very strong and they stop eating properly. Does eating also is related to our
See,
immunity?
there are many herbal, many other medications which are supposed to be immune boosters. So we should avoid taking
Immune
those
boosters.
immune boosters, right?
Mm.
But generally speaking, the normal diet,
Mm.
whatever we advise to patients, they don't affect immunity as much as immune boosters affect. Right?
Mm.
So normal diet should be taken. Whatever they used to take should be taken. Herbals and Ayurveda, I think, should be left aside and consulted with. They should consult with their team before taking those medicines.
Mm.
Normal diet is very much acceptable. Whatever they used to eat, they should keep on taking.
We have some patients who have phobia about eating
No.
anything.
Phobia should not be there. I will tell them exactly what to eat. I will also tell them that how they should eat and how eating affects their liver and body.
Rejection treatable.
Yes, of course. There are many rejections which are non-treatable, but there are many. The major kind of rejection, which I told you, TCMR or ACR, is treatable in more than 90% of patients. Right now, this acute rejection, when it happens it happens in initial 3 to 4 months, single episode of acute rejection is known to have no effect on long term graft survival, and it is treated in almost 95% of patients with steroid pulse. But if it's a late acute rejection, then chances of success are lesser. And if it is also not responding to steroid pulse, then chances of getting it corrected are lesser. That's why at first place, we have to be very compliant with our medication so that it doesn't happen. Secondly, in some patients, when they say that we have been taking our medicines very regularly, there are many reasons why rejection can happen. This is called as breakthrough rejection. You are taking medicines, but still rejection happens. Chances are very less, but it happens, right? And there are many reasons for that. The reasons is that one of the reasons is the variation in the levels of drug in the blood. Sometimes tacrolimus goes down, sometimes, and this can happen because of various reasons. 3 or 4 most common reasons are: if you're having any intercurrent illness like diarrhea, fever, or stresses of life, physical or mental, then levels can vary. Secondly, your diet. There are many components in the diet, which we are going to talk again, which can vary the levels. Like, for example, grapefruit, right? And very heavy fatty meal. Grapefruit diet, when taken with tacrolimus, can increase the level of tacrolimus multifold and cause side effects of tacrolimus like tremors, kidney failure, mental cloudiness. All these things can happen. So grapefruit from our side is no. Heavy meal, fatty meal, decreases the absorption of tacrolimus. So the level goes down. So one diarrhea, for example, diarrhea increases the levels of tacrolimus. Reason being, the cells between the intestine wall, they get separated and it gets absorbed very fast. So these are all the issues with bioavailability of the drugs. So what I would suggest, maintain a regular diet. Don't overshoot or under do the diet. Try to avoid intercurrent illnesses to avoid this breakthrough kind of a rejection. In some patients, like immune boosters, you said, if they keep on taking immune boosters, the drug level is maintained at this level, immunity goes higher, then there are chances of rejection. So please understand these aspects.
You also talked about late rejection. I personally don't worry about rejection because I feel I have already lived 10 years. Should I be worried about late rejection? Who would get it?
So we have talked about acute rejections, which are unlikely to happen at 10 years. So what kind of rejections can happen in a long term? They're basically chronic rejections, ductopenic rejections. But they are also common in patients who are not compliant with their medications. If you're taking your medications, maintaining your levels, then chances of chronic rejections are also less. Overall speaking, chances of chronic rejection are 3 to 4%
Mm.
overall.
Does it happen just overnight? Like one day you
No,
will
no,
get
no, no,
high,
no. You
or
will have
will it
signs
get
of,
signs
you
of
will
it?
have
Okay.
signs. You will have signs of alkaline. It's more of a cholestatic pattern
Mm.
where alkaline phosphatase, gamma GT, as well as bilirubin starts rising. slowly. Yeah.
Okay. And what would be your final advice and message to the patients?
So my final advice and message to the patient is that your medications, we have talked a lot about medications. Please, 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 every patient has a different need of medications, different dose, different type. Whatever has been prescribed to you, please stick to that. Don't ask your neighbor, don't ask any other person that what they are taking and then modify your medicines. Your medicines are your personal wallet, and they are fitting in need of, they are fitting the need of your liver as well as your immunity. So we call it as tailoring of these medications to the specific needs. So please take them as advised. Don't alter them without consultation with your doctors or surgical team.
Thank you very much, Dr. Vivek, for your time, for your wonderful advice.
Pleasure.